Welcome to Legends of Data and AI. Each episode includes inspiring and actionable data and artificial intelligence insights from global leaders across industries. Your host, Dr. Usama Fayyad, was the first Chief Data Officer at Yahoo and is Chairman of Open Insights and Executive Director of the Institute for Experiential AI at Northeastern University.
Hello, everyone, and welcome to another episode of our podcast, Legends of Data and AI. My name is Usama Fayyad. I'm the Executive Director of the Institute for Experiential AI at Northeastern University and Chairman at Open Insights. With me today, I have the great pleasure of having Dr. Rai Winslow, and we'll be discussing this whole interesting field of computational medicine and AI and AI in the life sciences from his perspective. Welcome, Rai. Great to have you here.
Thank you very much, Usama. I really appreciate being able to speak to you.
So, Rai, you've built a great career in building up this whole area of computational medicines and computational models of what happens to patients and disease and so forth. But I would love to get in your own words, kind of your background, both academically and professionally, before we kind of launch into a bunch of questions.
All right, very good. Even as a kid, I wanted to be a scientist. At very early age, I read a biography of Louis Pasteur, and I remember the conclusion of my reading that book very vividly. It was the moment I wanted to become a scientist, and I was always interested in biology and math, and I kind of switched back and forth on my primary interests, but it's the interest in biology and math has always been with me. But when I went to college, the math side of things won out, and I went and got a BS degree in electrical engineering at Worcester Polytechnic Institute, but retained my interest in biology. And this was a time when there were very, very few places that blended the two together. There were very few biomedical engineering or bioengineering programs at the time. So I went to worked in digital speech processing, and that even furthered my interest in speech and speech understanding and how the brain processes speech. So after working for 2 years in industry, I went back to school to get my PhD at Johns Hopkins Biomedical Engineering Department. I worked in auditory neuroscience, did experiments, but did a lot of modeling as well, and continued with that from that point forward. I went to a number of universities for different positions, but in 1991, an opportunity came up to go back to Johns Hopkins University Biomedical Engineering as a faculty member, and I did. And I spent 30 years there pursuing computational modeling of the heart, with the goal being to understand mechanisms, the fundamental mechanisms that give rise to arrhythmia in heart disease, and to use models to identify ways of better treating and preventing arrhythmia. In 2005, I started the Institute for Computational Medicine with two primary colleagues, Mike Miller, who's very well known and considered the founding father of a discipline called computational anatomy, and Don Gieman, who's a very famous machine learning, machine vision person who at the time had developed very strong interests in pursuing that in life sciences. And together we created the Institute for Computational Medicine, which I ran for 15 years. But then a headhunter called me and said, hey, there's this thing happening in Portland, Maine. It's called the Roux Institute. It's all about AI and machine learning and life sciences and medicine. What do you think? And I grew up in Maine and have always hoped to return in one way or another to Maine. And I thought, gee, I got to go see this. And I did. And I was incredibly impressed with the leadership and the vision and everything about it. And so joined in 2021. I joined to be Director of Life Sciences and Medical Research with academic appointments at Northeastern, and I have been pursuing and continuing this idea of computational medicine here at the Roux Institute in Portland.
Yeah, and of course, the Roux Institute was enabled by a major grant from Dave and Barbara Roux, and it's been and continues to be a game changer in Portland, Maine, and hopefully in the whole state of Maine. And we'll get back to some of that as we go through this. But let me go back and say, okay, how did the term computational medicine and the Institute for Computational Medicine, how did these arise?
Yeah, it's quite a story, actually. In early 2000s, I was, of course, doing computational modeling of the heart, becoming visible for that modeling, and developed a very, very close relationship with IBM. At the time, IBM had a life sciences division, and I worked really closely with a lot of people there and had a great working relationship with them. And they supported, in terms of major equipment donations, a lot of our research. And so one day, a development officer from Johns Hopkins knocked on my door and said, "Hey, Ray, what would you do if you had $100 million from IBM?" And I said, "Well, that's absurd." That's a silly question, but okay, I'll think about it anyway. And I did, and I came up with a notion of an institute completely devoted to the use of computational modeling to understand what disease is and how to quantitatively think about how to better diagnose and treat disease. The term computational medicine actually, and to complete that story, so I wrote a white paper and circulated it. And I think I sent it to the dean of the College of Engineering, the School of Engineering there, and the chair of computer science. And people in turn circulated that. And it just picked up steam. It was as if I did nothing other than write this white paper of what kind of institute I would create. That's all I did. And it took on a life of its own. And at the time, a new building was being built at Hopkins, and the president of the university spoke to me about this institute and my ideas. And he said, "You're going to be an anchor tenant in that new building." And the dean of the School of Engineering was a wonderful guy named Nick Jones, wonderful dean at the time. And he was very committed to interdisciplinary research. And he said, "I'm going to support your institute." And so they did. And it was just a magnificent thing. Now, the name came about in discussions with Mike Miller and Don Gieman, and we kind of all converged on the term computational medicine. And the funny thing is, we had to get the blessing of the dean of the School of Medicine because the title had the word medicine in it. And Ed Miller was the dean at the time, another wonderful, really driver dean of the School of Medicine, and he approved that, and it was all good. But it's just an interesting thing that use of the term medicine had to be formally approved at the school before we could run with it.
So what a great story, and wish we could all write a white paper and get 100 million.
No, it wasn't 100 million, I assure you.
Yeah. I know your initial focus was on modeling the heart and modeling heart disease and so forth. Care to tell us some more, like, what do you think of computational medicine, and how does it go beyond the heart? How general is it? How should we think about that as a field?
Yeah. So when I talk about computational medicine today, I define it in the following ways, and this is relevant to your question. So I give examples of what we do in computational medicine as the definition. And I consider there's three major things. And the first is to develop models of disease, mathematical and computational models of disease. The second is to understand how to constrain these models using data from patients to make the models patient-specific. And then the third is to harness the models in a patient-specific manner to help those patients to better diagnose disease, to do it more precisely, or to guide therapy. And your question, I think, really goes to part one of that, building models of disease. And I've deliberately chosen the word models because I mean that word broadly. The modeling methods we use are whatever are right for the problem. In my own work, the modeling methods that I used began really in dynamical systems theory and the use in the formulation of physics-based models, fundamental first principles models that really describe how molecular components interact to give rise to molecular networks, to collections of interacting networks and pathways in cells, and how cells interact with one another to generate properties of tissue, in my case, heart tissue, and of the whole heart, including structural description of the fiber organization of whole hearts and how that influences electrical conduction and arrhythmia. And so these models take the form of large systems of coupled nonlinear ordinary differential equations, which are numerically integrated, and that is a simulation of the dynamics of the system we're modeling. Every aspect of this, all of the fundamental principles that go into formulating these equations, which are the fundamental physics of how molecules interact with one another and how they bind with one another, and conservation laws, conservation of mass in particular. These fundamental physical principles apply to the description of all living systems. And so the modeling techniques, at least in the world of dynamical system theory, are totally universal. I've done neural modeling in my PhD work. I've done heart modeling, other kinds of modeling. Our team at the Roux does many different kinds of mechanistically based models of many different aspects of disease, which is not to say this is simple. It's not, because getting the information needed to constrain those models is really hard, slow, manually intensive experimental bench work. But we've always worked closely with experimentalists to do that kind of thing. More recently, I've explored another approach to modeling these systems, which is to harness machine learning methods. And here I'm asking different kinds of questions. We're not constructing detailed models of exactly how disease processes arise and how biological systems function in disease. Instead, these models are used to relate measurements that we make from patients or measurements that are made experimentally to phenotypes that we want to understand experimentally or outcomes that we want to predict in patients, and we learn a function that maps those features to those outcomes or phenotypes. Now, even though these approaches aren't mechanistically based, they can still provide tremendous insight into mechanism. If the machine learning methods used are interpretable in that you can rank order and identify the features, the particular measurements from patients or experiments that are relevant to this mapping and rank order them, then you get insight into the primary drivers of this relationship, which can still be very important and guide you in thinking in a more detailed way about mechanisms. So these are the approaches we use. In number two, it's very easy for me to say make measurements that constrain models, but it's very hard to do because we're still limited in what we can measure in real patients. Now, the world of biomedical imaging is very advanced, and modern imaging techniques do enable us to make structural measurements of mechanical function, of tissues, other functional measurements using PET and other kinds of markers that can now be imaged even in patients. So that's a very important source of data. Another important source of data, or of course, all of the kinds of multi-scale omic measurements that can now be made in a patient. You can sequence a patient in a day now, and under a day, and sequence the genome.
I mean, the story, it's fascinating how the layers kind of add up, and you wind up with this incredible amount of complexity as you make the models higher and higher fidelity. It is fascinating, though, that you are starting from the basic principles, from the molecular models, and going up. And kind of being your colleague at the Roux Institute in Northeastern, I've often heard you say that some of these models are as complex or more complex than the systems themselves.
There you go. Yes.
Yeah. So what I'm wondering here is if we can drill down a bit more on where, because if you start bottom up and you're including all these different data sources, it'd probably be helpful to explain where does AI, in particular, where does machine learning come in here to help, right? You've got a simulation going, it's generating a lot of data, you've got a very complex system, and you're thinking about maybe adding even more layers and more information into it. How do you see the role of machine learning, and how essential is it as one of the techniques or tools in the bag?
Yeah, there are two ways in which I'll answer that. And thank you for the question, because I think that's a really important thing for us to talk about. I really do feel that models are becoming so detailed and so highly integrated and so highly complex that they're approaching the complexity of the biological systems we wanted to understand in the first place. And so, therefore, one of the things that I think is very promising on the fundamental life sciences side of disease understanding is to learn much simpler representations of these complex models using machine learning methods, and to learn these models in very constrained and particular scenarios. And by that, I mean to focus on a complex model's ability to reproduce and predict responses to a narrow set of stimuli or under a narrow set of conditions, where the machine learning methods, in my view, then have an opportunity to learn the essence of how that is being done and to generate a much, much simpler description of that complex model that operates in that very narrowed domain of question asking and answering. And we have done that with very complex models of the cardiac myocyte, where the goal is to understand how does varying model parameters, which are, of course, the things that drugs target. These parameters that we're looking at are the things that are manipulated by drugs. And ask the question, what's the probability of an arrhythmia as different model parameters are modulated as they are in disease or as they are targeted by drugs? And in very narrow domains, you can build these models which make very accurate predictions of that probability, and which are then so simple that the models can be analyzed pencil and paper. And you can derive properties of these models that are really important, but that you couldn't possibly brute force compute using large models. Now, people use different names for this. They sometimes call reduced order modeling, or they call it fast models. I just call learning a simple representation. That's what I call it. But I think it's incredibly important because it is a way of not only simplifying models, but generating models that you can then do far more with, in principle, than you can even do with a complex computational model. It's really quite remarkable. So that's one whole important line of research that I think is really, really important in the life sciences. We can't move forward in integrative modeling of biological systems, dragging with us every single detail of the underlying biology, because then we'll have the hydra that you described in your question. And won't know what to do with it. So we have to do things like this. The second important thing is sometimes we're asking questions about patients for which we can't even come close to right now building a mechanistic model that we can bring to bear to answer those questions. It's just too multi-scale, too highly integrated a question, too complex, and the models don't exist. And so machine learning is a faster way of getting answers, in that we kind of bypass the detailed, hard-won, through experiments, understanding of biological mechanism, but we learn the relationship that relates what we can measure in that patient to what we want to predict in that patient. I personally think every single question an intensivist, a critical care physician asks every day when they see every patient can be complemented with such modeling approaches. And that really drives what I mean when I say medicine is going to become a computational discipline. It's that notion that models can enhance and aid in the decision-making processes of physicians, particularly critical care physicians, in everything they do. They will tell you that they are presented with an overwhelming amount of data whenever they walk into their patient's room and see all of that complex information on the patient monitor and all of the information that's in the EMR, and they struggle with how to integrate it. And models, I believe, can help them do that integration and help them in their decision-making.
No, I mean, I find that fascinating. And by the way, a lot of people in the field of AI kind of refer to that practice of looking at very complex models and trying to find a simplified representation, which is more understandable by humans, as what we call explainable AI. And it's a crucial part of kind of gaining trust between human expert, in this case, a physician or a surgeon, and kind of what's happening with these predictive models that are running at unimaginable complexities. I mean, even the data that you described that's available to a physician is still orders of magnitude smaller than the data that's going into these very complex models.
Yes.
So as we expand this, and as you think about computational medicine and its growth and its, I'd say, migration into, let's call it, routine use in a hospital system or a large hospital system, I know one of your goals is to kind of bring digitization and digital everything in medicine. Where does AI play another role? And I know you've been involved in several projects where you had machine learning, used to predict patient outcomes, to predict what would happen when somebody is downgraded from a ICU or upgraded. So maybe talk to us a little bit about the role of AI and machine learning in that setting.
Yes. So I think there are a number of areas that really span major activities in any acute care setting where AI can contribute. And you mentioned several of them, and I'll begin with predictive analytics. It's the idea of maybe it's fair to call this intelligent monitoring of patients as well, to collect data continually from the patient, use that data to quantify their state, and then, given that state, use an AI-based model to project their state forward in time to make reliable predictions about where they're headed. And the reason for doing that, of course, is if they're headed for a negative outcome, if they're headed for a significant deterioration in their health state, if we can identify where they're headed, what state they're headed to, well before it happens, we can provide that feedback to caregivers so that they can be aware and think about how to intervene to help that patient. And so doing that, of course, means, and you referred to trustworthy AI and building trust in AI predictions. Of course, that's on our shoulders. That's what we have to do with our physician and caregiver colleagues. They have to gain an appreciation of why a prediction is being made, and they have to gain an appreciation that if we can give them an assessment of the reliability of the prediction, then they can factor into that decision making. And in many instances, we have good ideas about how to compute that reliability. It's quite interesting, and it's quite important. And so that's one line of activity. Another line of activity, another thing that happens every day in the hospital, is diagnosis. So you can imagine a tissue biopsy being done on a patient's tumor, and the goal is to understand from that biopsy how that tumor will progress and affect the health of that patient. And so there are many teams around the world trying to understand this particular application area, which is sometimes called digital pathology. It's one aspect of digital pathology. And it's an example of how taking a measurement, in this case a biopsy, in a physician's office or in an acute care setting, is then harnessed through AI to make improved predictions about what's going to happen to that patient. There's another very interesting project that we're working on, and it's based on the fact that there are some common diseases, relatively common diseases, which present in the emergency room, but which have a high rate of misdiagnosis. And the misdiagnosis can lead to mistreatment, inappropriate treatment of the patient, and a significant mortality rate results from the misdiagnosis of common diseases. Now, this is remarkable and a very important emerging application area of AI, I believe, will be to help limit and reduce the rate of misdiagnosis of common diseases. So there's many different scenarios where AI can contribute to diagnosis. Another major area is what I call patient flow control. Should a patient be admitted to an ICU, which of course they all have a limited number of beds, it's important to make careful decisions about who should be in an ICU and who shouldn't be. And when is it safe to discharge a patient from an ICU to a step-down unit? Or when is it safe to discharge from the step-down unit to home? Or another example is operating rooms. There's a finite number of operating rooms in any acute care setting. It's important to be able to triage the patients who are staged for operations, so those who need it most urgently, perhaps it's not quite the right way to say it, the patients who need a surgery now in order to not be delayed, because that delay could result in a significant deterioration of their health state. So we want to prevent that. We want those patients in the ORs. We want the patients who can safely wait to be the second most important tier to get into. Every acute care setting faces this. So there's many patient flow control kind of problems. All of these problems are really prime for AI, because we are not at a spot yet where mechanistic models can address these kinds of problems. We have to use machine learning methods and AI to do it.
And Ray, this is it's a fascinating arc to go all the way from these highly complex, high fidelity simulations all the way to observational settings where you're kind of reading certain things like vitals and other measurements, and then trying to guess what lies beneath in order to help decide kind of the right progression, the right treatment, the right dispensation. You often, and related to this, you often talk about an evolution to AI becoming a member of the medical team. Maybe a few words on what does this mean to you, and why is it so important to think about it as a member of the team who's kind of perhaps making recommendations but not decisions?
Exactly. That's why it's important, because that's the sense in which they are a team member. So I think, and I think I said it earlier, that medicine is becoming a computational and an engineering-based discipline, and that is because in all the ways that we've discussed up to this point, models of one kind or another are going to be operating on data from patients and providing feedback to caregivers. And I gave an example of one kind of feedback. In the predictive analytics problem, the feedback is patient X is heading towards condition Y. And there could be a reliability assigned with that prediction. We're 80% certain this is going to happen. And we can provide a rough time window within the next 12 hours, within the next day. There's a high probability of transitioning to this more challenging healthcare state. And so in the kinds of problems we're working on now, that's what we're providing back to the caregivers. It's not a directive about what to do. It is simply a piece of information that the caregiver then considers along with everything else that they've learned about to consider in making their decisions. I almost think of these recommendations as being like the result of a laboratory test on a blood sample, like a lactate level. It's just information coming back to the caregiver, who then synthesizes that information and uses it to enhance and enable better decision-making on their part. What's interesting to me is that the information can be used in so many different ways. So an attending physician will care about what's the state of my patient, where are they headed, and how do I intervene? But a charge nurse might, knowing that this latter category is in the domain of the attending physician, a charge nurse who's head of a unit might want to know, how many really sick patients who are headed towards trouble will I have tomorrow? Should I bring in 2 or 3 additional staff members with specialized care to be in the unit tomorrow? So it's just interesting how caregivers' roles and responsibilities can harness the same kind of information in different ways. I also think this means that caregivers in general, physicians in particular, need to be trained in new ways differently than they are now. You know as well as I do. In fact, 2 weeks ago, there was an article in the New England Journal of Medicine entitled AI in Medicine, with a lot of other stuff, but AI in Medicine. And it was about, as the name says, the impact of artificial intelligence in medicine. It's coming. In New England Journal of Medicine, that same journal, you see quantitative AI-based research articles now. And to understand those articles, caregivers need to be able to read them and think critically about them, evaluate their strengths and weaknesses, and know what that article means for their practice, just in the same way that they can read an article on a clinical study or a set of experiments and do that now. They're trained to do that now. They need to be trained to do a critical interpretation of these AI-based methods that are going to be appearing in every mainstream clinical journal as we move into the future. And they already are, in fact.
And another reason I love your term, that AI as a member of the medical team, is because it also creates the right attitude and environment for, be it the physician, the nurse, the surgeon, whoever, to provide feedback to the algorithms. Hey, you're wrong here. Hey, this is interesting. I didn't think of that. And that feedback and interaction actually builds trust, because then they feel like they contributed to the evolution of the system, to its ability to learn and become better, and that sense of ownership. Let me head towards a wrap up here, because we're running through our time. What do you believe are the limitations of AI-based approaches? What should people pay attention to when they hear about the amazing power and advancements of AI?
I will mention one limitation which has been raised with me, a fear and anxiety, if you will. And it's, by the way, it's not, is AI going to replace my job? I think you have a wonderful expression in regard to that. AI isn't going to replace your job, but a human who knows about and uses AI may replace your job. I love that, by the way. And so the anxiety is that physicians and caregivers could rely too much on AI, that the decision, or I shouldn't say decision, a recommendation from an AI system could be accepted in a non-critical and non-evaluative manner by caregivers, and that this wouldn't be good. And it goes back to what you just said about AI being a member of the healthcare team and their particular role, which is to make recommendations. And it's always, in my view, going to be the responsibility of caregivers to think critically about their patients and to treat that AI-based piece of data or recommendation the same way that they treat other kinds of data, to think about it critically and always know that they are fundamentally responsible for the well-being of their patients, and therefore they can't blindly accept the recommendation of an AI system. They're always responsible for their decisions, must always think very carefully about them. And so the anxiety I've heard is that, what if physicians and caregivers don't take things that way? What if they just blindly accept the recommendations of AI systems, which are going to make mistakes? We hope to dramatically reduce the rate at which machine systems make mistakes. But humans always make mistakes. Machines will make mistakes at some rate. And so machine can't be responsible. The human caregiver has to be responsible.
Absolutely. And those are great words of wisdom to leave our audience with from you, is basically take it as a recommendation from the AI. Think about what the AI is doing. It is not immune to errors. In fact, if anything, it can make many silly errors, and we got to keep our vigilance. Rai Winslow, Director of Computational Medicine and Life Sciences at the Roux Institute, Professor at the Bouvet College of Health Sciences and at the College of Engineering at Northeastern University. We are very lucky to have you at the Roux Institute and back in the state of Maine. And we thank you for taking the time to share these insights about computational medicine with our audience.
I really appreciate your questions, Usama, and really value as a colleague, and the fact that you've shown in this interview that you really listened to me. You've retained what I said. That's a rare quality, that people listen to others and take it in. So thank you very much. I hope I've said some things that are worth listening to.
Always worth listening to, and always worth remembering, Rai. So with that, I'm Usama Fayyad, Executive Director of the Institute for Experiential AI at Northeastern University, Chairman at Open Insights. Thank you for joining us on this episode, and we look forward to talking to you in a future episode of Legends of Data and AI. Thank you.
Thanks for listening to Legends of Data and AI. We hope you enjoyed our deep dive into the world of data and AI. If you're keen to learn more about making data and AI work in the real world and in any organization, join us next episode and subscribe to the podcast. As always, you can head over to open-insights.com to sign up for our email list, learn more about the work we do, and have access to data resources. See you on the next podcast.